Hello, my name is Jean-Pierre Després. I'm Scientific Director of the International Chair on Cardiometabolic Risk. And I'm joined here today with Professor Peter Libby from Harvard, who is a well-known academic cardiologist and is a member also of the ICCR. I'd like to address the issue today of the dismal recent figures published on the percentage of the American population who are in optimal cardiovascular health. Now, with the objective of improving the cardiovascular health of the nation, the AHA has identified a very simple criteria to define what is cardiovascular health. Three biological well-known factors have been obviously considered: cholesterol, blood pressure, and diabetes, but also behavioral health factors such as having a normal body mass index as an indicator of being in energy balance, not smoking, having a healthy diet based on very simple criteria, and performing 150 minutes of physical activity per week. And Peter, what we have learned from the epidemiological studies that have quantified the percentage of population reaching the optimal levels for these simple criteria is that 0.1% of the population in the United States or even in China have optimal cardiovascular health. So as a scientist, as an academic cardiologist, what do you think of those figures?
Well, I think we're sitting on a powder keg of risk. In my specialty, we're very good at dealing with the end stage of cardiovascular disease, and we're quite facile with doing interventions and trying to treat the end stage of the disease. But I think we need to look through the other end of the telescope. And I'm particularly concerned about a coming epidemic of cardiovascular disease because our youth, as you point out, is not observing those simple, healthy factors. Now, the biological risk factors we can do something about with medication. But I think that we have to target our interventions much earlier, or else we're going to pay an enormous price in terms of health, and also in terms of the resources that are going to be required to deal with this coming epidemic if we aren't able to prevent, in a much more fundamental level, the factors that lead to this accumulation.
You refer to health resources. We both work in Heart Institute, and I'm fascinated by the fact that when we see those patients, coming with acute coronary syndromes, obviously now we're extremely sophisticated in terms of making sure that we relieve the symptom and we revascularize patients. But when you look at the mosaic of cardiovascular disease risk factors, maybe they smoke less, but we see more and more now of those patients that have too much fat at the wrong place. I'm sure you have the same experience at your institution.
Absolutely. And I think that the public is aware that we have so many tools for dealing with the end stage of the disease that it lulls them into a sense of complacency that they don't have to mind the risk factors, because they think that we can fix things. But all of our medications, all of our interventions, both surgical and percutaneous, really are just putting the finger in the dike. And I think that we need to be better educators in our profession. And we also need to use our role as community leaders to try to address at a much earlier stage what you call the minestrone soup of risk factors that really set the stage for the coming epidemic of cardiovascular disease.
Because obviously it has been a source of some satisfaction, our ability to lower cholesterol with pharmacotherapy, same thing with blood pressure. But with this influx of patients, sedentary patients who are abdominally obese and who have type 2 diabetes, maybe they are kept alive, but they are extremely sick.
Yes, I think that the high technology approach is one that is bankrupt, both professionally and economically. And it's much more cost effective for us to reach much earlier in the history of the disease and try to change behaviors. And that's why I'm so enthusiastic about the work that we're doing here in the International Chair for Cardiometabolic Risk. because I think that we really need to focus our attentions much earlier in the disease process.
And the interesting thing about this, these very simple criteria to quantify ideal cardiovascular health is the attention given now to the behavioral risk factor, to physical activity and to the quality of the diet that appears to have a very robust weight in risk prediction.
Yes, but you know, we really need to invest much more in research in how to change behavior. I alluded previously to our lack of skills at communication and motivating our patients. And we spend far too much time on the one-to-one medical model of dealing with the patient who's in front of us and their particular pressing problem that day, renewing their prescriptions, dealing with all of the high technology side of the equation. But I think that we need to invest much more in effective ways to communicate, effective ways to modify behavior, to complement our fluency really with the high technology and of our specialty.
And in closing, now you and I are physically active because we believe this exercise is good medicine. Your views about the dismal, poor cardiorespiratory fitness of our children in terms of the future of cardiovascular health of our respective nations?
Well, you know, we're engineering physical activity out of our contemporary society. I think, again, we need to don our hats as community leaders to try to make sure that physical education is protected in the school systems. Our kids are very facile with their joysticks and their computers, but I think that we need to encourage physical activity in youth much more than we do. And I think that we need also to build sidewalks and bicycle paths in our communities to make it possible for physical activity to be part of daily life.
We're clearly dealing with a societal disease, and the ecology of this problem will have to be carefully examined. So thank you for this interesting discussion, Peter. We will certainly revisit this issue and pay a close attention to it in the future. Thank you.